It is just like a VKH, but it is quite it has all the disease process like VKH, but it is usually related to trauma. Then there is a systemic manifestation similar to those in VKH can occur but are uncommon. Prognosis depends on the severity and location of the disease and the response to treatment. With aggressive therapy, 75% of the sympathizing eye retains a visual acuity of better than 60. Long-term follow-up is mandatory because relapses occur in 50% of the cases and may be delayed for several years. Investigation. OCT is useful for quantifying and monitoring change. B-scan ultrasonography may demonstrate choroidal thickening. FA shows the multiple foci of leakage at the level of RP with subretinal pooling in the presence of the exudative retinal detachment. So these are all the investigations that you can do in a case of a sympathetic ophthalmitis. ICGA show hypofluorescent spot in active disease which resolve with treatment. So ICGA will show the hypofluorescent spot, whereas the FA will show the leakage and hyperfluorescent spots with the subretinal pooling in the case of a ERD. Ultrasound may show choroidal thickening and exudative retinal detachment. So what is the treatment? Enucleation of a severely injured eye within 10 to 14 days of injury has historically been considered effective in preventing or reducing the severity of the sympathetic ophthalmitis and should be considered for injured eye with the hopeless visual prognosis. So if you do the enucleation of the eye within 10 to 14 days of the injury, it can prevent the sympathetic ophthalmitis. Evisceration is an acceptable option provided all the uveal tissue is removed. Steroids are basis of an initial treatment. High-dose oral prednisolone is given for several months and gradually tapered according to response. Initiation with the intravenous methylprednisolone may be used in some cases. Supplementary topical steroids and cycloplegics may be given to target anterior uveitis, and peri and intraocular steroids, including slow-release intravitreal implant, may facilitate reduced systemic treatment. So basically, steroids are mainstay of treatment like in the VKH. Immunomodulatory treatment should be considered early in the course of disease. So you can see this is a histology of the sympathetic ophthalmitis. A is showing infiltration of the choroid with lymphocyte and scattered aggregations of epithelioid cells, many of which contain fine granules of melanin. Dellen B is showing Dellen's Fuchs nodule, a granuloma situated between the Bruch's membrane and the RPE. 12.24 shows the sympathetic ophthalmitis, a large KPs in sympathizing eye. B is showing multifocal choroidal infiltrate, and C is showing residual chorioretinal scarring after immunosuppressive treatment. Next is the lens-induced uveitis. Lens-induced uveitis, lens-induced or phacogenic, previously phacoanaphylaxis uveitis result from an immune response to lens protein following exposure due to incomplete cataract extraction, trauma, or rarely capsular degeneration in the mature cataract. The most commonly encountered modern scenario is that of a retained lens fragment following phacoemulsification either in the posterior segment after posterior capsular rupture, or zonular dehiscence, or an overlooked piece of nucleus or soft lens matter settling in AC. This must be differentiated from bacterial endophthalmitis, which is usually more severe. So basically, lens-induced uveitis is when the lens protein are exposed because either the capsules are ruptured due to trauma or during the phacoemulsification or any surgery when the capsule is compromised and there is a leftover lens material that remain in the AC. It can cause the phacoanaphylactic uveitis. So what are the features? There will be the variable pain, photophobia, and redness, blurring, usually with a history of recent complicated or uncomplicated cataract surgery, and uncommonly of the injury. Anterior uveitis is granulomatous, may be mild, moderate, or severe. So they're going to be the anterior uveitis. They're going to be corneal edema is common adjacent to the AC lens fragment. IOP is frequently elevated. Lens fragment may be visible in the exterior or posterior segment. Vitritis of variable severity is usually present if the lens fragment lie within vitreous cavity. Lens injury may be evident in case of associated with trauma. Complications include cystoid macular edema, glaucoma, epiretinal membrane, and rarely more severe sequelae such as retinal detachment and cyclitic membrane. Investigation, OCT, scan, and biomicroscopic ultrasonography may be indicated. Treatment involves steroids. The route and the intensity depend on the clinical circumstances, with the surgical removal of lens material from AC or bypass sclerovitrectomy as required. So basically, lens is protein is causing the uh, this type of uveitis. So in this case, removal of the cause is also important. If there is a very large lens protein or lens matter present, then the major treatment is to remove it. But if it is a very small amount, then the steroid can do the job. Small lens fragment in the posterior segment can often be managed conservatively and will absorb slowly over months. Cycloplegics and IOP loading treatment are commonly indicated. Penetrating or blunt ocular injury should be managed concomitantly as appropriate, including removal of the damaged lens. So this is a lens-induced uveitis, exposed lens material producing an inflammatory reaction. So that's it for the part 7 of the uveitis. See you in the next lecture.